In this lecture, I'm going to talk about the pathophysiology of erythropoiesis. This lecture composed of two parts. The first one, we are going to talk about the decreased erythroid cell. This is what is called anemias. And in the end, I'm going to talk about when we do have too many erythrocytes, so that we have polycythemias. So let's start with anemia. Anemia is relatively, it's meaning that we do have a reduced oxygen delivery capacity of the blood, and this is why the peripheral perfusion is inadequate. One thing that you have to keep in your mind, anemia is not a disease, but rather an expression of the underlying disorders or diseases. So you should not be satisfied to diagnose anemia, because usually this meaning that we do have another underlying problem that caused anemia, that caused the decreased circulated red blood cells. Now anemia can be detected in laboratory by the decrease of the hemoglobin concentration or the hematocrit or the red blood cell count. When we evaluate these lab values, we have to rule out the hemodilution or hemoconcentration. For example, if somebody got an infusion before you were taking the samples, that could dilute the blood cell count. Or if somebody is exsicated, that can cause hemoconcentration. Now, occasionally, sometimes the hemoglobin is abnormal, and this is why the hemoglobin has a or increased affinity to the oxygen, and this is why in the periphery they are not going to give the oxygen to the peripheral tissue, so relatively the oxygen cannot diffuse out from the hemoglobin binding, and doesn't matter what was the hemoglobin concentration or hematocrit or red blood cell count in the periphery, we could have hypoxia, so oxygenation disorders. Now, let's say something about the normal situation and how we are going to diagnose anemia. The red blood cell count or the hemoglobin is depending on the gender. Males usually has a higher number of the red blood cells, or the consequence, a higher concentration of the hemoglobin and hematocrit. So these are the upper limit or the lower limit of the red blood cell count or hemoglobin or hematocrit. If we fall below, this is what we call anemia. Usually we consider the hemoglobin concentration. This is what the WHO offering or suggesting us. So if, for example, the male has a less hemoglobin concentration than 130 gram per liter, and in case of the female, less than 120 gram per liter, this is what we call anemia. Now, in most cases, the hemoglobin concentration correlate very well in the oxygen carrying capacity, and these clinical signs a patient should be considered, identify the causes of the anemia. This is what I mentioned before. So you should not be satisfied to diagnose anemia. Now let's see what kind of anemia, anemia diagnosis can be made based on the hemoglobin concentration. If we do have a hemoglobin concentration that is ranging between 95 and 109, that's a mild form of anemia. Of course, the sign of anemia or the clinical sign of anemia is going to depend on the development, how fast this anemia develops. If it develops very fast, usually they do have clinical symptoms. If not, if it's a chronically developing situation, relatively we have no clinical sign. So this mild form relatively is associated with no clinical sign. If we do have a moderate kind of anemia, the patient usually complains of fatigue or weakness, And in case of the severe anemia, when the hemoglobin is ranging from 65 to 79 and the hematocrit is around 20 or 25, dyspnea and tissue hypoxia can develop. And when we drop the hemoglobin concentration below 65, that's a critical situation, confusion and loss of consciousness or myocardial MI, or a lot of things can develop in the patient. Now, what can be the symptoms of anemia? I already mentioned some. However, as I mentioned before, the symptoms depend on the severity of the anemia, rapidity of the onset, and the patient's age and cardiovascular status. If it's very severe one, as we discussed before, we can have different symptoms. If it develops rapidly, the symptoms can be more advanced, and especially in elderly patients, especially in those who had some cardiovascular problem, they could develop different and more severe symptoms. Now, let's see the symptoms and let's talk about what kind of symptom, what kind of organ manifestation of the symptoms can be. First of all, it can be cardiovascular and respiratory symptoms, such as dyspnea, tachycardia, palpitation of angina. Neurological symptoms, such as the headache, dizziness, or fatigue, or what you can see on the skin, pallor of skin, mucosous membrane, nail beds. But there are some gastrointestinal syndromes, such as anorexia, or nausea, or diarrhea, or constipation. Further constipation can develop. Or genitourinary tract can be affected, menstrual cycle irregularity, or amenorrhea, or loss of the libido or impotence can develop in case when we do have anemia. Now, the classification of anemia usually based on the laboratory parameters. As we will learn about it, the red blood cell size and the red blood cell hemoglobin content be the parameters that we are using to classify anemias. Based on the size of the red blood cells, MCV, we will have microcytic when the cell size smaller, normocytic when the cell size normal, or macrocytic anemias when the size of the red blood cells are bigger. Based on the hemoglobin content of concentration of the red blood cells, we will talk about hypochromic anemias, normochromic anemias, and hyperchromic anemias. When we do have less hemoglobin, that's a hypochromic. When we do have a normal amount of hemoglobin inside red blood cells, that's the normochromic. And when we do have more hemoglobin in one red blood cells, that's called hyperchromic anemia. Now, usually, because what we do have inside the red blood cells is a hemoglobin, that's a major content of the red blood cells. This is why the microcytic anemia is associated with hypochromia, or normocytic usually has a normochromia, and macrocytic has more hemoglobin. This is why those usually hyperchromic. Based on the pathophysiology, we can talk about those situations when we do have a decreased red cell production, and that can involve for the myeloid stem cells, or we do have a problem with the hormones that usually stimulate the erythropoiesis, such as a defect in erythropoietin, or we do have a defect in the red blood cell maturation. With this red blood cell maturation, meaning can be the altered hemoglobin synthesis or altered DNA synthesis. Another possibilities that can lead to the decreased red blood cell count when we do have an increased loss or excess destruction of the red blood cells. That can be due by losing the red blood cells, for example, bleeding out, that's a hemorrhage. Or when the red blood cells are destroyed, that is hemolysis. Now let's look first the normal erythropoiesis. The normal erythropoiesis is starting from the pluripotent stem cells, and very early this pluripotent stem cells is dedicated to the myeloid stem cells, and the myeloid stem cells dedicated to the burst forming unit of erythroid stem cells. Here you can find the different cytokines or factors, colony stimulating factor, that is going to drive this maturation and the production of these early mature or early dedicated cells, such as interleukin 3, for example, or granular monocytic colony stimulating factor, or interleukin 9, or IGF-1. This is going to drive this maturation. And as you see here, in the late and before the colony-forming unit, the erythroid colony-forming unit, that's the erythropoietin is coming into the picture. And later on, when we do have this early, already dedicated erythroid cells, that is going to convert to proerythroblast or proerythroblast, and proerythroblast going to convert it or maturate it to the basophilic erythroblast, and of course this is going to divide as well, and we have more and more maturated cells. So the basophilic erythroblast or normoblast, polychromatophilic erythroblast or normoblast, orthochromatophilic, and after these cells is losing the nucleus by a karyorrhexis, is expelled from the cells, and reticulocytes formed. Now, here in this case, when we do have the proerythroblast, basophilic, and polychromatophilic, what we do have, more and more hemoglobin is accumulating into the cytosol. This is why the iron uptake will increase. Another important one, to have a early or colony forming unit formation that's needed about almost 2 weeks, and from this colony forming unit we need about 5 to 7 days to produce reticulocytes. Of course, it will depend on the number of the red blood cells, or let's see the degree of hypoxemia. If we do have more hypoxemia, we do have a higher values of this factor that stimulates the erythroid synthesis or the erythropoietin synthesis, and this is taking shorter time to produce red blood cells. Now, every red blood cells enters to the circulation in the form of reticulocytes. These reticulocytes is a ribosome remnant, so still some protein synthesis is going on inside these reticulocytes, and that stays in the circulation only for 24 hours or so. If it's getting, let's see, a younger one, because you do have a more stimulated erythropoiesis, usually the reticulocyte stays longer in the circulation, but what means it still have some protein synthesis going on. Now, after 24 hours, or in a younger one, maybe 48 hours, this ribosome remnant is lost, and we do have the mature erythrocytes. One very important aspect of it, that is no further protein synthesis. So if we do have any kind of noxa that altering the proteins or enzyme in the red blood cells, that red blood cells is relatively will die very soon. Now, what kind of factor control the erythropoiesis? I already mentioned in the previous graph. This factor is going to control the growth and the maturation of the stem cells, such as the interleukin 3, interleukin 9, or granular monocyte stimulating factor, and erythropoietin. The erythropoietin mainly synthesized by the kidney due to hypoxia, or in the liver as well. Let's start the anemia when we do have a decreased production or decreased maturation rate. This is called aplastic anemia. Aplastic anemia is characterized by an acellular or hypercellular bone marrow which will cause pancytopenia. Pancytopenia means that not only the red blood cell count will decrease, but the granulocyte number, the platelet count, it will decrease as well. At the right side, you do have the normal bone marrow, and here the hypocellular, almost acellular, fibrotically converted bone marrow that we have. Now, what can cause aplastic anemia? That can be the quantitative or qualitative abnormalities of the pluripotent stem cells, or abnormal humoral or cellular control of the hematopoiesis, such as the missing of interleukin-3 or granulomonocyte clone stimulating factor. But it can be some microenvironmental problem, for example, a damaged stromal cells. So it looks like the hostile function of the bone marrow is altered. Or immunological suppressed hematopoiesis can happen. We do have some kind of autoantibodies that circulates and causes the damage of the stem cells. That can be humoral or autoantibody mediated, or can be cell mediated when we do have a T cell abnormalities, or lymphokine mediated process that can decrease the stem cell. Now, anemia could be caused by renal failure as well, especially in chronic renal failure. Now, what is going to affect this, or what will cause this anemia? First of all, if we do have an excretory failure, when we do have less and less water excreted, this is why the hyperhidramia, it will cause a dilution of the red blood cells. This is why the hematocrit value will decrease. Another thing, because we are not excreting the waste product, this toxic material can reduce the red blood cell survival. That can be metabolic or mechanical problems as well. Or the uremic toxins can suppress the bone marrow function. Or we do have some nutritional factors that is lost, for example, iron or folate, that usually is due to the chronic hemodialysis, or impaired platelet function that is leading to the bleeding tendency, or excretory function that can, for example, alter the erythropoietin synthesis or production. Now, anemia in liver diseases or in cirrhosis can develop possible due to a multifactorial effect, such as the lipid composition of the erythrocyte membrane. This is why the hemolysis will increase. So the phospholipid synthesis, lipid abnormalities that altering the membrane, or increased plasma volume associated with cirrhosis. This again can cause hemodilution. Or another problem, that is splenomegaly due to the portal hypertension can decrease not only the platelet count but the red blood cell count as well. Here in this graph, you can see the arrows pointing at a little spike is red blood cells when the membrane lipid layer is altered. This is called acanthocytes. That's very typical for the cirrhosis. Another thing, when we do have a decreased erythropoiesis, is due to some endocrine disorders, such as a hypothyroidism or hypopituitarism that involves the androgens or growth hormone deficiencies. IGF-1 was included, for example, in this erythropoiesis, or hyperparathyroidism that altering the extracellular milieu in the bone marrow. Let's start and let's discuss the altered hemoglobin synthesis when we do have a problem with the hemoglobin synthesis, whatever inside the red blood cells. This is going to cause, it's called microcytic hypochromic anemias. These are the most common cause of microcytic and hypochromic anemias, such as iron deficiency, anemia of chronic diseases, in some cases because mostly it can cause normocytic normochromic anemias, thalassemias, hemoglobinopathies, and sideroblastic anemias, and some heavy metal toxicity, some lead toxicity can cause this. Now, this little graph that involves everything what you learn in biochemistry, so how the hemoglobin synthesis is going on. First of all, we do have the porphyrin synthesis in the mitochondrium. And of course, when we made, let's say, this hemoglobin, or the heme is incorporating the globin, and this is what making the hemoglobin. And it will incorporate the iron in the middle. So this is how we do have the hemoglobin is formed. The iron is usually uptaken by the cells, is an endocytosis, okay? And from the transferrin is liberated and stored inside the cells in the cytosol in the form of the ferritin. Mostly the phagocytic system is going to store the ferritin. Now, however, as you know here, not only the heme synthesis is important, but the globin synthesis, the protein synthesis is very important to have a normal hemoglobin formation. Let's start with the most common type of the problem, and that's the iron deficiency anemia. Now, normally we do have relatively about 1 gram iron in the stores. We do have about 2.3 gram in the red blood cells, and in the tissues we do have some additional 0.5 gram, and in the circulation we do have about 3 milligram iron. Now every day we are losing and absorbing about 1 milligram iron. So this is the normal turnover of the iron. What will happen when we do have an iron deficiency? First of all, we are going to lose the iron from the stores. This is the first thing. And after, we do have less iron in the red blood cells, as you see here. And that will initiate the absorption, the increase of absorption of the iron. That can go up to 10 milligrams per day. Instead of having 1, we can have about 10 times higher. But of course, the excretion depends on the cause of iron deficiency. Now, the stages of iron deficiency. We do have, this is what is called pre-latent iron deficiency. In this case, the stored iron already decreased, and we know that the iron is stored in the form of the ferritin. So when the ferritin level, the soluble ferritin that can be measured in the plasma, that decreases, it's meaning that we do have less stored iron. Later on, we do have the latent iron deficiency, and then we do have an impaired erythropoiesis already. So the serum iron level decreases, the transferrin level increases, the soluble transferrin receptor number increases, meaning that in the periphery we do have iron deficiency. So those cells that taking up the iron, they are hungry. This is why they're expressing more transferrin receptors. And for the transferrin saturation, it will decrease. However, the red blood cell, about the 10% of the red blood cell can be only microcytic one. So this is not manifested yet. Manifested iron deficiency, meaning that's the iron deficiency anemia. In this case, the hemoglobin decreases, the red blood cell count decreases, the hematocrit decreases, the red blood cell morphology will alter. That can cause anisocytosis, meaning that the size of the red blood cells varies, or poikilocytosis, when the shape of the red blood cells are altered, or microcytosis can happen. So it meaning that not less than 10%, but more than 10%, mostly about 90 up to 90% of the cells are smaller ones. That not only the red blood cells can be altered, but the patient usually has an elevated platelet count. The patient has thrombocytosis. Now, why do we have thrombocytosis? Because anemia stimulates the erythropoietin synthesis, and erythropoietin is homolog to the thrombopoietin. This is why the elevated erythropoietin can stimulate the, the platelet formation as well. Now, what can cause iron deficiency anemia? Very commonly, chronic blood loss. This is what we learn, for example, in GI tract bleeding, and mostly in those who are over 50 years old and coming to the physician with iron deficiency, especially a man, very, very high incidence. They do have a colon carcinoma, and they do have a very small amount of blood that lost every day, and that can lead to iron deficiency. Now, uterine bleeding or hematuria, pulmonary hemosiderosis again can cause iron deficiency anemia in the long term. Or in some cases, we do have an increased iron requirement. For example, in periods of rapid growth in infancy or adolescence, but during pregnancy, the mother needs about an extra 1 gram iron. And during lactation, every month, the mother needs about 30 milligram of iron. Now, another problem can be that we cannot absorb somehow the iron. That can be some kind of intestinal mucosal disorders, such as the celiac diseases or tropical, non-tropical sprue. Or if somebody suffered of the subtotal gastrectomy and due to the rapid transit through the duodenum, or less acidity, for example, in the stomach, that is achlorhydria, that the ferro conversion is catalyzed by the acidity, is not performed well, so it's less absorbed. Or perioperative blood loss or acute bleeding secondary to recurrent ulceration. So a lot of things can cause an iron deficiency anemia. Or when we do have an inadequate iron intake, that can be a vegetarian diet. So because the best iron in the best iron that can be absorbed very well, and that's the hemoglobin bound iron, so the blood containing food that has a lot of iron that can be absorbed very well. But vegetarians, for example, a vegetarian diet has less iron, plus the complex fibrate can inhibit the iron absorption, or can be infection or repeated pregnancy or lactation, or hookworm, for example, that can use up the iron and can lead to iron deficiency. Now, the symptoms of iron deficiency, relatively these symptoms and signs pertaining to anemia can be non-specific one. That's usually the general sign of anemia, such as fatigue, weakness, shortness of breath, pallor, tachycardia, and so on. However, the iron deficiency can cause some specific sign, such as atrophic changes in the epithelium, in oral, for example, oral lesion, angular chylosis, or atrophy of the tongue papillae where intermittent glossitis and stomatitis can develop. Or dysphagia can be due to the postcricoid esophageal webbing, that is called the Plummer-Wilson syndromes, for example. Or nail lesion, flattening of the nails, and brittle and spoon-shaped nails. That's a colonychia, could be specific to iron deficiency. Or there's a pica, that is compulsive ingestion of non-nutrient substance, somebody eating clay, dirt, paint, and in that ice, clay, and laundry starch, that again is binding the iron and lets iron can be absorbed. Now here, for example, the dysphagia, I'm showing you the iron deficiency anemia caused this Plummer-Wilson syndrome, when we do have a little postcricoid web causing the feeling defect, so we do have a swallowing problem with the patient. The next one is the anemia associated with chronic diseases. Now, this is definition usually in men over 85, especially in hospitalized one. There's a very huge amount of people suffering of anemia with the chronic diseases. Usually these patients suffering as a chronic disorders such as the malignancy or infectious or inflammatory stasis. Now what will happen? The patient will have low serum iron level, low total iron binding capacity of the serum, However, they do have a normal bone marrow iron stores or further can be increased. So this is why the ferritin level in this patient usually is normal. Now, etiology. Of course, is infectious diseases, especially the chronic infectious inflammatory diseases such as a tuberculosis or pneumonia or a bacterial endocarditis or osteomyelitis can cause this. Or chronic non-infectious inflammatory disease such as sarcoidosis or some autoimmune disorders such as SLE or rheumatoid arthritis. But malignancies such as carcinoma, lymphoma, or sarcoma can be associated with anemia. Now, what is the pathophysiology of these chronic disease-associated anemias? Basically, we do have an increased level of the apolactoferrin that is somehow is shortcutting the metabolic pathways of the iron. But interleukin-1 level is elevated and stimulates the fever and stimulates the increased retention of the iron by the macrophages. That's the hepcidin synthesis will increase, and that's shortcutting or storing the iron, so it's inhibiting the release of the iron from the stores. Mild hemolysis could occur in this situation because the lifespan of the red blood cells decreases the normally about 120s, and that can decrease to 60-90 days. And in this patient, a relative bone marrow failure can occur, so the erythropoietic level usually is about 50% patient is lower than the normal. Now, I mentioned already the hepcidin that is produced by the liver, and the function of the hepcidin that regulate the iron release from the cells, so that is regulating the ferroportin. Now, if we do have a chronic inflammatory reaction, the hepcidin level it will increase, and hepcidin is going to close or going to remove the ferroportins from the surface of the cells. So this is why the ferritin is going to be accumulated inside these stores. How can we diagnose this situation? First of all, we could see the sign of a chronic inflammatory disease or malignancy. When we measure the serum iron, it can be low or normal, but the total iron binding capacity is decreased because the transfer level is decreases, and the saturation, transfer saturation is low. And we do have a lot of stored iron in the store. This is why the hemosiderin is increased. And when you give iron to the patient, this won't cause reticulocytosis immediately, so they are not going to stimulate the red blood cell production, so it's not responding to the iron therapy. The next, I'm going to talk about the heme synthesis problem, the sideroblastic anemias. Now, here you can see the heme synthesis, the precursors of the heme synthesis. The first step in the mitochondrium that's going on, this is regulated by the delta aminolevulinic acid synthase. This will have a rate limiting step. If you do have a problem with this enzyme, this is usually an X-linked chromosome disorder. This is what we call the sideroblastic anemias. If we do go further down and we do have this enzyme defect, that can include, for example, the porphyrinogen deaminases or uroporphyrinogen decarboxylases, we do have an accumulating of the precursors, and these precursors has light sensitivity and they will cause the clinical problem. In the disease on the right side, you can see what we will cause. For example, lead poisoning is associated when we do have the delta aminolevulinic acid dehydratase, for example, or further acute intermittent porphyrias, for example, as this associated with porphyrinogen deaminases, or porphyria cutanea tarda, we do have a problem with the uroporphyrinogen decarboxylases. And lead poisoning again can alter the ferrochelatase activity as well. Now, In sideroblastic anemias, that's a diverse group when we do have a blockage of the heme synthesis at the very early level when we do have the delta aminolevinonic acid synthase. In the body, we do have ring sideroblast in the bone marrow. We do have a decreased level of the porphyrins without accumulating of the pyrols, and we do have an excess iron stores in the mitochondria. Now, the classification of the sideroblastic anemias that includes the hereditary sideroblastic anemias, where the sex-linked chromosome, usually the recessive or inherited disorders, very, very rare conditions, or that's more common, the acquired sideroblastic anemias. This can be the primary acquired sideroblastic anemias that relatively associated with the myelodysplastic syndrome and in elderly patients. Later on, we will talk about it. And the secondary acquired sideroblastic anemia, usually the drug-induced problem. For example, isoniazid and that inhibits the heme synthesis, such as the chloramphenicol or azathioprine, or drug-induced myeloblastic syndrome over time, this alkylating agent, if it's used, or alcohol, it has a direct toxic effect of the mitochondrium, or can cause sideroblastic anemias. Now this is how it looks like when we do have in a bone marrow, and that's a Berlini blue staining method, and you can see the ferritin or the iron is accumulating inside the cells. If you do have time, please watch this movie. This series is Dr. House, so House MD, and third series in episode 9 when a girl who had the sideroblastic anemias, and you can see what kind of symptoms can be associated with the sideroblastic anemias. Porphyrias. In porphyrias, when we do have or an inherited defect in the heme synthesis, and in a consequence we do have an accumulation and excretion of porphyrins. Now, of course, the pattern is going to depend on the enzyme defect. In decreased heme synthesis, the decreased hepatic, for example, delta aminolevy synthase, and these are more commonly, this is autosomal dominantly hereditary disorders. And that can be influencing only the erythropoiesis or some hepatic or mixed form of these two. Can be acute and can be chronic. In acute case, that can be the neurovisceral attack, for example, the gut pain and abdominal pain can occur in this patient. And porphyrin accumulation can cause photosensitivity and the formation of reactive oxygen species and can damage the tissues, the skins, and the release lysosome can damage further the tissues. Now, what clinical sign of the porphyrias can be? The photosensitivity that I mentioned, and these free radicals can cause keen inflammatory reaction or neurological symptoms. For example, stomach ache or peripheral neuropathy can develop, and a central nervous system involvement can cause, for example. What is the essential or what is the leading of this? Usually we do have an increased production of the delta aminolevinic acid and the porphobilinogen in this case. Now, an acquired porphyrias or this intoxication that can be due to the lead intoxication or hexachlorobenzene toxicity. You see here the photosensitivity, it is completely scarring the tissue of the patient, and the lead can be seen, for example, in the mucosa and accumulate in the mucosa. Now, what causes the neurological symptoms in porphyrias? Usually the structure or ALA is similar to the GABA, and this will activate the GABA receptors. And the levels of the heme-containing protein decrease to the critical level, and this will alter the ATP synthesis, and the central nervous system needs a lot of energy, and this again can cause the neurological symptoms. Now, a long time ago, they pay, let's see, a scientist or almost a scientist, David Dolphin, in 1982 is reported in the Times magazine, and he hypothesized that the vampires could have porphyrias, and this is maybe those patients who suffered of porphyrias, they were the vampires one. Now, why did they say this one? Because porphyria victims are extraordinarily sensitive to the sunlight. Very similarly to the vampires, they cannot go out to the sunlight because the skin can be damaged. And to avoid the sunlight, people with the serious cases of porphyrias go only at the night, just like Dracula. Now, porphyrias can be treated with injection of blood, so transfusion, for example. Centuries ago, porphyrias victims might have thought to treat themselves by drinking blood, but that's ridiculous because it's not the same. It's not, they cannot get some blood transfusion by drinking the blood, you knew it. And porphyria is inherited, but the symptoms may not manifest it themselves until brought on by stress. Suppose a siblings with an active case of the disease bite you, which is thirst for blood is stressful, isn't it? Now, garlic contains a chemical that worsens the porphyria symptoms, causing suffers, and this is why the vampires avoided basically the garlic. Now, this of course is not true, but if you compare, let's see, a patient who suffers of a severe porphyria to the vampires, they can be very similar one, especially if they're suffering a severe necrosis and the gingiva, for example, is atrophied and looks like the teeth, it looks like the vampire teeth. The next, we mention some about the thalassemias. Now, as you know, the hemoglobin synthesis or the globins is different in different stages of the fetal life or the normal life. At the beginning, we do have a fetal hemoglobin that composed of alpha and gamma globin. And right before the delivery occurs, the gamma is exchanged by the beta globin. And this is why we do have a normal adult type of hemoglobin that composed of 2 alpha and 2 beta globin part. Now, these globins, the alpha and beta, gamma, and delta, located in 2 different chromosomes. While alpha is located in the chromosome 16, then others, delta, gamma, and beta, located on the chromosome 11. Normally, we do have the major part of the hemoglobin is hemoglobin A that composed of 2 alpha and 2 beta chain. But a very low amount we can have the fetal type of hemoglobin, alpha and a gamma, and the A2 type when we do have a delta and alpha hemoglobin. Now, the globin synthesis and thalassemia syndromes, that's inherited abnormalities in the globin synthesis that caused by the mutation in the chromosome region that containing the globin genes in the chromosome 16 and 11. We can talk about alpha thalassemias and beta thalassemias, whichever genes are affected. If we do have alpha thalassemias, we do have a problem with the alpha gene synthesis with the alpha gene. So we do have a reduced production of the alpha chain. Usually this is due to the gene deletions. And because we do not have in major thalassemias, we have no alpha, we will have, let's see, beta, delta, and gamma. And we can have, the patient will have hemoglobin age when we do have 4B globins or the Bar's hemoglobin that 4 gamma globins. In beta thalassemias, we do have a reduced production of the beta globin chain. That's usually due to an RNA abnormalities that with the point mutation, and this is why we do have less A type of hemoglobin, but both A2 and the fetal type it will increase. Now, of course, in any case that is happening, because these hemoglobin, they cannot absorb or cannot release the hemoglobin as the open air, as the normal A-type hemoglobin. This is why this patient usually suffers of hemolysis. Now, the diagnosis, what we make, usually is using the hemoglobin electrophoresis, but it can calculate, for example, the Manser index. The Manser index that considering the MCV, the volume of the red blood cells, and the red blood cell count. Now, if you divide the MCV by the RBC, we can have mostly iron deficiency anemia if this quotient is bigger than 13, or thalassemias when the quotient is less than 13. So this is how the hemoglobin electrophoresis looks like in a normal situation. We do have the A type of hemoglobin. We do have A2 of the fetal type. Now, if somebody does have, for example, a beta thalassemia, that the trait that they are carrying only, relatively it's missing that the beta gene is less. So this is why the A is less and the A2 be higher one, the hemoglobin A2 be higher one. However, when we do have the major beta thalassemias, what we do have, that's almost no hemoglobin A, and we do have the fetal type and the A2 type that is increased. Now, the next one, the hemoglobinopathies. The hemoglobinopathies is different from the thalassemias because here we do have an inherited point mutation of the globin genes. So we do have globin genes, we do have alpha, beta genes, but these the globins varies, is a little bit altered. The most famous one, the sickle type of the hemoglobin S, when we do have a point mutation that the glutamic acid is mutated to the valine. And what will happen? The solubility is going to decrease. But there are zillions of the hemoglobin pathies that usually altering the solubility or the abnormal oxygen transport or affinity is altered in this situation. Let's focus on the hemoglobin S or the sickle cell anemias. Now, when we do have the sickle cell anemia, and we do have the hemoglobin S, relatively that is going to have a decreased solubility, especially in the acidic environment. And this decreased solubility will cause a polymerization of this hemoglobin, and they are forming these rod-like materials. Now let's see where these sickle cells are formed. When we go to the capillaries, what will happen in the capillaries in this milieu, in the hypoxic milieu? The shear stress is going to alter the shape of the red blood cells, and when they are going through the capillaries, these red blood cells cannot, no, it's not a flexible, it's irreversible change, and they will show these sickle cells. Of course, in the next circulation, these sickle cells can attach together, and that can plug the vessels, and they can cause hypoxic changes, and especially hypoxemia in certain areas. Now, this is how the clinical features develops in sickle cell diseases, especially when we do have a sickle cell crisis that usually suddenly developing a pain through the bodies and different areas, for example, the bones, lungs, abdomen, joints, and due to the lack of the blood flow can cause the pain and organ damage. And this graph summarizes the typical symptoms of sickle cell anemias. Now again, when we look at the hemoglobin electrophoresis, you will see in sickle cell anemias that we do have this hemoglobin S is a different migrating band, and it's showing that the patient has a sickle cell anemia. Now again, in the next series, we are talk about the different problem, these megaloblastic anemias. And again, Dr. Ha's series, this is a third series in episode 14. Please watch it. That can be very interesting one. Now, when we do have an abnormal DNA synthesis, this is what will cause megaloblastic anemia. Now, of course, in the periphery, we do have a macrocytic anemia, macrocytic and hyperchromic anemia. But this is not the same as megaloblastic anemia. Megaloblastic anemia is a bone marrow diagnosis, what we do have in a bone marrow. Macrocytic anemia is a peripheral diagnosis. Not only megaloblastic anemia can cause macrocytic anemia, but there are some other things, such as, for example, alcoholism or hypothyroidism can cause it. In a true megaloblastic anemia, when we do have a problem with the DNA synthesis, and mostly this is due to the folate or B12 deficiencies. Now, the very characteristic difference between the alcohol-induced macrocytic anemias, that's in the periphery, we do not see any hypersegmented neutrophils. However, when we do have a megaloblastic one, we do have a hypersegmented neutrophils or hypersegmented eosinophils in the periphery. In the next, we do have the hemolytic anemias. Hemolytic anemias meaning that we do have a decreased circulating red blood cell count due to the premature destruction or removal of the red blood cell from the circulation. Normally, the red blood cells lives about 120 days in the circulation. Now, certain factors is going to influence this lifespan. Usually can be the cellular factor, that the enzyme that is located inside the red blood cells, or the cytoskeleton that is affecting this red blood cell survivor. However, there's some environmental factor that affecting the red blood cell survivor, such as the excessive mechanical stress or increased temperature or toxin chemicals that in the circulation that also is affecting the lifespan of the red blood cells. But there are some immunological factors that again can alter the red blood cell survivor. So hemolytic anemia means that we do have an increased red blood cell destruction. Now, what will be the consequence? We do have usually a normocytic normochromic anemia. And the red blood cell survival rate is shortening. And due to the hypoxemia, we do have an increased production of the erythroid precursors, red blood cells. So we do have reticulocytosis. Now, very, very important one, that a destruction of the red blood cells, usually they won't be manifested unless the lifespan of the red blood cells reduced to 20 days. So the bone marrow can increase the production rates about 6 times. Now, the cause of hemolysis can be categorized as intravascular versus extravascular, meaning that where does hemolysis happen, whether intravascularly or extravascularly. This is how can we see it? We can measure the haptoglobin level, because if the haptoglobin level and hemopexy level decreases relatively, it meaning that we do have an intravascular hemolysis, because in the circulation, in the plasma, when we do have a release of the heme or hemoglobin, these two carrier proteins is going to bind this component, and after being bound is uptaken by reticular endothelial system, so phagocytic system. However, when we have an extravascular, it's meaning that directly the phagocytic system is going to eat up the red blood cells. And of course, in both cases, usually the indirect bilirubin will increase. And again, another thing, what are the causes of this hemolysis, whether this is due to some extracorpuscular problem or some intracorpuscular problem. So this is how we can fish out the cause of hemolytic anemia. We do have another important type of anemias or hemolytic anemia. This is what is called paroxysmal nocturnal hemoglobinurias. Now, what it does, basically the patient in the morning wakes up and they do have dark urine. And and later on the patient can develop iron deficiency as well. Now, what is the meaning of it? Usually at the night when we do have a lower pH due to a hypoventilation, so the respiratory acidosis develops at the night, and in acidic milieu we do have a excess hemolysis. Later on I'm going to discuss it. Thrombosis in both venous and arterial vessels, Budd-Chiari syndrome, for example, and spontaneous platelet aggregation can happen in this patient. And not only the red blood cells alter, but usually other platelet and, for example, the white blood cell count decreases. So we do have a pancytopenia of the patient. And when the morning the patient had hematuria, later on hemoglobinuria, later on it's going to clear up and nothing happened. And that's repeated about every 7 days or so. Now, how can we diagnose? We can use the Ham test or sugar water test when we acidify red blood cells and activate the complement system, and that causes the hemolysis. Now, what is the problem? The problem is that's stem cell disorders and an acquired stem cell disorders when in an abnormal stem cells, this is a PNH2 and 3, we are missing this PIGA protein, missing the GPI proteins, or what's called the CD55, CD59, PIGA-A protein, that's going to regulate the complement binding. And in those cells, they don't have this PIGA protein, the complement will bind to these cells in acidic milieu and destroy the cells, destroy the red blood cell, destroy the platelets and other cells. Now, how can we prove it? Usually they're measuring the CD55 and CD59 level. The next part is the polycythemia when we have more circulating red blood cells. Now, usually if we do have the venous hematocrit that is higher than 65%, this is what we mentioned as polycythemia. But not only the red blood cell count increases, but the viscosity rises exponentially. This is why the patient usually could suffer of heart problem later on, or it's be more difficult to push through the capillaries to the red blood cells, and the patient could have some circulatory problem as well. Now, the primary polycythemia, or it's called polycythemia vera, usually is one of the chronic myeloproliferative diseases that's characterized by the clonal proliferation of myeloid cells in which the bone marrow produces too many red blood cells. In other cases, usually that it belongs to myeloproliferative diseases, we will have an extra lecture about it. We can have thrombocytosis, for example, or we can have increased myeloid cells, such as a chronic myeloid leukemia, this belonging to the same, or myelofibrosis. And here we do have more red blood cells. That's a polycythemia vera. Now, the secondary one, it's very common one usually. Usually it's appropriate apo or tissue hypoxia. And for example, that induced by pulmonary diseases or working in a high altitude or living in a high altitude or congenital heart diseases or having abnormal hemoglobin, and they do have a higher affinity, for example, and they are not dissociating out, or carboxyhemoglobin concentration can increase the EPO, and this is why we do have a secondary polycythemia. Now, another thing, we can have an inappropriate EPO or ectopic EPO production can occur due to tumor, for example, hepatomas or renal carcinomas, lymphomas, hematomas that can secrete EPO, or renal disorders, transplantation or cysts, for example, or hemangiomas, as I already mentioned, or androgen abuse, Or APO abuse, for example, in a biking patient who was he wanted to get some extra, for example, oxygen, and they use this APO, but now they are stopped using it. Or familiar polycythemia, again, that can cause these polycythemias. Now, let's see the symptoms and the sign of the polycythemias. The symptoms usually involve some circulatory problems, some headache, for example, weakness, pruritus, or dizziness, diaphoresis, sweating, or visual disturbances and weight loss. And the sign mostly involves splenomegaly, or spleen plethora, the reddish skin, or hepatomegaly can develop in 40% of the cases, or plethora, conjunctival plethora, or systolic hypertension can occur in this patient, very common. How do we diagnose? The diagnosis is basically based on the number of the red blood cells. If the red blood cells mass is elevated, or I mentioned before, if the hematocrit concentration is over 65%, all right, and the saturation usually, the oxygen saturation, arterial saturation is over 92%, splenomegaly, but the patient could have thrombocytosis, leukocytosis, or high level leukocyte alkaline phosphatase, or high vitamin B12 level, for example. In any case, when we do have a polycythemia vera, we have to differentiate from the secondary causes, for example, or we have to differentiate from myeloproliferative neoplasm diseases as well. And in smokers and drinkers, again, we can have a false positivity, for example, for polycythemias as well.